Hello, everyone, and welcome to today's live broadcast, utilizing same-day sepsis pathogen ID for faster therapy, enhanced stewardship, and improved outcomes, presented by Dr. Cornelius Clancy from the University of Pittsburgh. I am Xavier Gutierrez of LabRoots, and I will be your moderator for today's event. Today's educational web seminar is brought to you by LabRoots and sponsored by T2 Biosystems Incorporated. For more information on our sponsor, please visit www.t2biosystems.com. Now let's begin. Before we get started, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click on the Send button. We'll answer as many questions as we have time for at the end of the presentation. If you have trouble seeing or hearing the presentation, click on the Support tab found at the top right of the presentation window, or report your problem by clicking on the Answer a Question box located on the far left of your screen. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located at the top right of the presentation window and follow the process to obtain your credits. I'd like to now introduce our presenter, Dr. Cornelius Clancy. Dr. Clancy is the Associate Professor of Medicine in the Infectious Diseases Division and the Director of the Mycology Program at the University of Pittsburgh. Dr. Clancy is widely published and a respected scientific expert on novel diagnostics. He is a leading researcher on antimicrobial resistance in bacteria and fungi and their clinical relevance. Dr. Clancy, you may begin your presentation.
My name is Cornelius Clancy from the University of Pittsburgh. I also go by Neil Clancy. And today I'll be talking about T2 nanodiagnostic panels for the diagnosis and identification of pathogens causing bloodstream infections. So as you all know, bloodstream infections are associated with significant morbidity and mortality, and the timely administration of appropriate antimicrobials is a crucial determinant of outcome among patients. So for example, on the right here, data from Kevin Gary showing outcomes and mortality among patients with Candida bloodstream infections and showing significant increases in mortality rates among patients for each day that the initiation of appropriate antifungal therapy is delayed. And there are similar data for bacterial bloodstream infections. Blood cultures are considered the diagnostic gold standard for identifying bloodstream infections. However, we know that these are limited by suboptimal sensitivity ranging from 10% among patients with suspected bacteremia up to 50% in patients with septic shock. And we know among patients with Candida bloodstream infections who have hematogenously disseminated candidiasis, sensitivity is also 50% or less. And blood cultures are further limited by slow turnaround time, which delays the institution in many instances of appropriate antimicrobial therapy. So the insensitivity of blood culture presents a challenge then both to clinicians caring for patients and for new research on novel diagnostic tests. And in the clinic, the impact is obvious. Delays in the institution of treatment contribute to poor patient outcomes. And conversely, the inability to make accurate and timely diagnoses promotes empiric and preemptive antimicrobial usage, and with that, the development of antimicrobial resistance. On the clinical trial end, the insensitivity of blood culture presents a challenge for us in interpreting what the meaning of discordant, new diagnostic test positive, blood culture negative results really mean. Are these patients who are false positives on your new diagnostic test, or are they true positives that are in fact missed by the insensitive blood culture? And for this reason, there's been interest in looking at composite microbiologic and clinical criteria in clinical trials that assess the performance of new diagnostics. And we'll get into this a bit more during the presentation today. So the United States Food and Drug Administration in September of 2014 cleared the T2DX instrument and the T2Candida Panel for the direct detection of Candida species within whole blood samples from humans with suspected invasive fungal infections. And in fact, this was the first FDA clearance of a diagnostic direct from blood test for the identification of bloodborne pathogens. And just last month, in May of 2018, FDA cleared the T2 bacteria panel, again using the T2Dx platform, this time using whole blood samples to detect 5 leading bacterial causes of bloodstream infection. And to date, T2Candida and T2 bacteria remain the only direct from blood diagnostics cleared by FDA. So both T2Candida and T2 bacteria are automated, rapid culture-independent systems, and they run on this fully automated instrument shown here in a picture on the bottom, a desktop instrument. You take a blood tube of 4 mLs, pop it directly into the machine. It'll automatically lyse cells, amplify DNA targets from the Candida or bacteria of interest. It agglomerates the particles, nanoparticles with your amplified DNA, and it detects and identifies the pathogens by magnetic resonance, and hence the name T2 magnetic resonance nanodiagnostic particles. So the T2Candida panel has limits of detection for what we call the big 5 Candida species at 3 CFUs per ml or less, depending on species. And this will give results reported in one of 3 ways: as positive for Candida albicans or Candida tropicalis, Candida glabrata or Candida krusei, or positive for Candida parapsilosis. And these pathogens account for 95% or more of invasive candidiasis at most centers. And they also have particular susceptibility patterns that can allow you then to make rational antifungal choices based on what the anticipated susceptibility of the different species would be. The T2 bacteria panel, as I mentioned, identifies 5 bacterial species: Enterococcus faecium, Staphylococcus aureus, gram-positive bacteria, and the gram-negative bacteria of E. coli, Klebsiella pneumoniae, and Pseudomonas aeruginosa. And these big 5 species account for 50% or more of bloodstream infections, and the sensitivity is comparable to that of the T2Candida assay, with density as low as 2 colony-forming units per ml of whole blood being detected. So my objectives today are going to be to review the performance of T2Candida and T2 bacteria in diagnosing bloodstream infections, and to compare the performance with that of blood culture. And we'll pay particular attention to patients who are receiving antimicrobial agents at the time of testing. Secondly, I'll talk about the clinical significance of these discordant T2 positive blood culture negative results for both the Candida and bacterial panel. And then finally, I'll discuss strategies for how we might rationally develop patient management strategies that incorporate these tests and bring them into clinical practice. So let me start with T2 Candida, and then I'll take a similar approach to T2 bacteria in the second half of the presentation. So FDA clearance was based largely on data from this multi-center clinical trial, the so-called DIRECT-1 study. This is performed at 15 U.S. centers, involved over 1,500 prospectively collected blood samples, which were largely negative for any Candida or bacteria. And in fact, only 6 patients enrolled in this patient had a blood culture that was positive for one of the 5 Candida species that is detected by the T2 Candida assay. There were also 250 contrived blood samples that were spiked with various concentrations of the 5 species that are detected. And with these samples, the sensitivity and specificity of T2 Candida, as shown on the bottom of the slide here, were 91% and 99% respectively. And the turnaround time for the test was 4 hours plus or minus 1 hour, compared to 5 plus or minus 1 days for blood culture. So FDA cleared the test based on these data, but there were 2 major questions that were left unresolved at the conclusion of DIRECT-1. And the first is, since only 6 patients actually had candidemia in the original DIRECT-1 trial, what is the clinical sensitivity of the test in real-world clinical experience? And then a second question is shown here on the bottom of the data presented to the left, where 29 or almost 2% of the patients in the original DIRECT-1 study, in fact, had these discrepant T2 Candida positive blood culture negative results. 29 patients. And the question is, what is the significance clinically of these discrepant results? So my objectives will be to answer both of these questions. And to get at this first, I'll review data from the DIRECT T2 study, which was published recently in Clinical Infectious Diseases. And this was a multi-center trial at 14 US centers, most of whom participated in Direct 1 as well. It involved adults greater than 18 years of age, and it had an interesting study design. Patients were enrolled at the time that a diagnostic blood culture was reported as positive for Candida. And then at that point, patients were enrolled, and 2 to 3 days later, after the diagnostic blood culture came positive, a follow-up T2Candida and companion blood culture were drawn simultaneously from the same access site. And the blood culture was always collected immediately prior to the T2 sample from the same site. So T2Candida and the so-called companion blood culture drawn at the same time were defined as positive if they identified a Candida species that was identified in the corresponding diagnostic blood culture that was originally drawn and identified a Candida species. The primary endpoint was T2Candida clinical sensitivity, which was defined as the T2Candida positivity in patients who had, at the same time, a positive companion blood culture. The secondary endpoint was T2Candida performance among the entire cohort of patients who were originally identified by the positive diagnostic blood culture. And we included patients who were both receiving and not receiving antifungal agents at the time of enrollment into the trial to mimic clinical practice and how the test would be used in the real world. And here are the results. So after exclusion, 152 patients were enrolled, as shown here on the left. And the median time from collection of the original diagnostic blood culture and then the collection of the subsequent T2Candida paired companion blood culture was 55 hours. Here we can see the patient clinical characteristics and demographics, and simply to point out that this was a typical patient population that would be enrolled in candidemia trials, and also to draw attention to the fact that 3/4 of these patients were in fact receiving antifungal agents at the time of enrollment into the study. So at the time that the T2 sample and companion blood culture were drawn, they were already on antifungal therapy. Here's a breakdown of the Candida microbiology. You can see on the pie chart here, the biggest slices are for Candida albicans, Candida glabrata, and Candida parapsilosis, which were enrolled in equal numbers. There were fewer patients who had Candida tropicalis or Candida krusei infections, and then a handful of mixed species infections. So here's the primary endpoint, which is the T2Candida clinical sensitivity, and it was 89% among 36 patients who had a companion blood culture that was positive for one of the 5 species detected by the T2 panel. In fact, the T2 positive result identified the same Candida species in 32 of those. You'll notice then that in 4 patients, the companion blood culture was positive. However, the T2 sample simultaneously collected was negative. So if we look at the results among the entire cohort of 152 patients who were enrolled based on their diagnostic blood culture result, T2Candida was positive in 45% of those patients, or 69, compared to companion blood culture being positive in 24% of those patients, or 36. And in fact, the T2Candida was significantly more likely to be positive at the time of enrollment into the study than were companion blood cultures. And interestingly enough, there was no difference whatsoever among patients who were not receiving antifungal therapy. The positivity rate with T2Candida and companion blood cultures was approximately 30% in each. However, T2Candida was significantly more likely to be positive than the companion blood culture among the 75% of patients who were already receiving antifungal therapy, 50% of T2 positive versus only 20% of the companion blood cultures positive, and this was highly statistically significant. So if we break down the combined T2Candida and companion blood culture results, we get this flow chart, again, starting with the entire cohort of 152 patients. If you just go to the bottom row there, you can see that T2Candida and companion blood cultures were simultaneously positive, both positive, in 20% of patients. On the bottom right, you see that both tests were negative, T2 negative, companion blood culture negative, in just over 50% of patients. And then within the red box, you get the discrepant test results. You see the 4 patients who I previously mentioned who were T2 negative companion blood culture positive, representing 3% of the entire cohort. And then 37 patients, or 25% of the entire cohort, in fact, had T2 positive companion blood culture negative results. So we know these patients were originally candidemic from the diagnostic blood culture. So T2Candida identified 37 patients who were missed by the companion blood culture, compared to only 4 patients who were identified by the companion blood culture and missed by T2Candida. And similar to what I just showed you, the strongest independent predictor of a T2 positive blood culture negative result was in fact the previous receipt of antifungal therapy. So identifying patients, primarily those who are already receiving antifungal therapy. So that brings us then to our next question. What is the clinical significance of these discordant results, and in particular, these T2 positive blood culture negative results? And data are now emerging to get at the biological and clinical significance of these findings. So the first study I'll cite was published recently in the Journal of Antimicrobial Chemotherapy. This was by Patricia Munoz and a consortium out of Madrid, several hospitals there who've used T2Candida in a couple of novel ways. So the first study they did was a prospective observational study of patients who were receiving definitive antifungal therapy because they had a positive blood culture and therefore had positive proven candidemia. And the endpoint of this study was the development of complicated candidemia, which they defined as attributable mortality or the development of metastatic deep-seated candidiasis as a complication of bloodstream infection. So they did longitudinal testing with T2, with blood cultures, and with serum beta-glucan in this study. So within 5 days of the original positive diagnostic blood culture, if you had a positive T2 result, that was an independent risk factor for the development of complicated candidemia. And in fact, the odds ratio was 36. The sensitivity of a T2 positive result within 5 days for identifying patients who would develop complicated candidemia was 100%. The specificity was 76%. And in this cohort, the positive and negative predictive values for complicated candidemia were 64% and 100% respectively. So I'll draw particular attention to the 100% negative predictive value. It meant if the T2Candida test was negative, none of these patients went on to develop complicated candidemia. So very much a marker for good treatment response and good outcome. And in fact, blood culture or serum beta-glucan did not correlate with outcomes whatsoever. So indicating that there was clinical and biological significance to the T2Candida result that is not seen with the other tests, including blood culture. So I'm sorry, I messed up the slides there a little bit, but a second study then out of the same consortium in Madrid, and again published in the same edition of the Journal of Antimicrobial Chemotherapy by Patricia Munoz and her colleagues. This was another prospective observational study, and what they did here is, rather than studying definitive blood culture proven candidemia, they studied empirical antifungal therapy among patients who were receiving treatment for suspected but not definitively diagnosed Candida bloodstream infection. And what they found here is that a positive baseline T2 after starting antifungal treatment was an independent risk factor for the subsequent development of either death or proven candidiasis, with an odds ratio of 26. And again, neither the serum beta-glucan or in this case, Candida albicans germ tube antibodies correlated with outcome. So prognostic significance at the time of initiation of empiric antifungal therapy for poor outcomes among patients who had T2 positive results. Again, showing that there is clinical relevance to T2 positivity. So I'll show you some of our data then locally at the University of Pittsburgh getting at this question as well. So we enrolled 32 patients from UPMC, the University of Pittsburgh Medical Center, in the DIRECT-2 trial. And in fact, mortality at 30 days among these patients was 19%. So 6 out of the 32 patients died. If we break down then the mortality outcomes among our patients at 30 days by T2 Candida and blood culture results, this is what we get. So if patients were positive by either the T2 Candida or the simultaneously collected companion blood culture, the mortality rate was 50%. If the T2 positive companion blood culture negative results were obtained, the mortality rate was 33%. If T2 Candida negative companion blood culture positive discrepant events were obtained, mortality was 50% again. If you look at the group in whom both tests were negative, T2 Candida blood culture negative results shown on the far right of the graph there, mortality in this case was only 5%. So if we look at this another way, if we take any patient who had a positive T2 Candida, the mortality rate was 40% compared to only 9% among those in whom T2 Candida was negative, a strong trend towards significance there. Similarly, if we look at patients who were companion blood culture positive, mortality rate of 50%, companion blood culture negative, mortality rate of only 12%. Again, another strong trend. But if we consider the tests together, where either both T2 Candida and blood culture were positive, or either test was positive, the mortality rate was 42%, compared to only 5% among patients in whom both tests were negative. And this, in fact, was statistically significant. So similar to the data out of Spain, our experience indicates that T2 positive blood culture negative results do have clinical relevance and do identify a patient population that is more likely to have bad outcome than in patients in whom both tests are negative. So based on this performance, can we devise rational patient management strategies that allow us to incorporate T2 Candida into the treatment of our patients? And in thinking about this, I think the best approach is to consider patient populations who are at varying degrees of risk for candidemia and ask how the test might perform in those populations. And one thing that's nice about candidemia is we know from the literature there are very well described patient risk groups, and we have a good sense of what the pretest likelihood of candidemia in these various populations is from a large body of clinical experience that's been collected over several decades. So here's a table that presents that data. So if you take any patient in whom a blood culture is collected for any indication whatsoever, so this would basically be the direct one study design. The prevalence of candidemia in that cohort is only 0.4%. However, if you then start talking about subgroups of patients, say, who are admitted into the ICU, or hemodialysis patients with line infections, the likelihood of candidemia in that setting goes up to 1%. And then from there, you can define different populations with increasing risk of candidemia. For example, septic shock patients, patients with ECMO or left ventricular assist devices, up to say a 10% pretest likelihood among patients who fulfill various prediction scores for the development of candidemia, such as the mycosis study group prediction score that Louis Ostrowski and others have published on. So if we assign then pretest likelihoods based on these patient populations and characteristics, and we assume that T2 Candida is going to perform as suggested by the two direct studies with sensitivity and specificity of 90 and 98%, we can calculate what the anticipated positive and negative predictive values in the respective populations would be. And what we can see then is as the likelihood of candidemia increases, the positive predictive values increase. The negative predictive values in all settings remain very, very high. And in fact, even in your highest prevalence group, those who fulfill a prediction score for candidemia, the negative predictive value is still 99%. So I'll point out, in the lowest risk group, your negative predictive value is excellent, greater than 99.9%. However, this is a group in which you're essentially starting with a negative predictive value of 99.6%. So in fact, the test doesn't really add all that much to what you know already going into ordering the test on the patient. So it's less likely to have value here than in patients who are at higher risk of candidemia. I'll also point out on the table to the right here, if you assume that T2 Candida isn't going to perform quite as well as in the direct studies, but instead is going to perform more like PCR assays and PCR meta-analysis literature for candidiasis, which suggests sensitivity and specificity of PCR assays of approximately 90% and 90% respectively. What you see there then is you get the same pattern where the positive predictive values will increase, but your positive predictive values at each pretest likelihood are lower than they would be if the performance is truly 90 and 98% respectively. However, you'll also notice that the difference in negative predictive values among these patients is less striking. So the negative predictive value, even if the performance is 90% sensitive and specific, still works very, very well. So how do we use this to manage patients? And the fact is, we don't know what the threshold likelihood of candidemia is that justifies empiric or preemptive antifungal therapy. However, there's a large body of literature from critical care populations, from bone marrow transplant recipients, that suggests empiric antifungal therapy is effective at preventing antifungal infections at a pretest likelihood of about 15 to 30%. So if we take that as our cutoff for initiating antifungal therapy, it would suggest that any diagnostic test is going to have the greatest utility if it takes us from below that likelihood to above that likelihood, while at the same time maintaining excellent negative predictive value. So where would that come into play? And in fact, if you go back to our table, within the red blocks here, you see those patient populations at different levels of test performance in whom you go from below the positive predictive value as a pretest likelihood to above it after getting your test result. And in each of these instances, the negative predictive value is still excellent. So within the box is where you'd anticipate T2Candida testing would have the greatest utility. So I'll focus here on patients with septic shock. So I've got it listed in the table here as a 3% prevalence or pretest likelihood. In fact, the literature would suggest Candida accounts for anywhere from 3 to 10% of septic shock. So with that, it would suggest that septic shock is within the fat part of the utility curve for T2Candida and is a population whom the test may have particular value. So with that, at the University of Pittsburgh, what we did in rolling T2Candida out is we focused in our medical intensive care unit on patients who had septic shock, with an idea that we'd anticipate that 3 to 10% of those patients actually had candidemia. And then with that, we'll exploit the positive predictive values if tests are positive to initiate antifungal therapy in patients with a positive test result. Among patients who are already started on antifungal therapy, conversely, we'll use the excellent negative predictive values in conjunction with blood cultures to discontinue antifungal therapy in patients who are at low risk of actually having candidemia. So this has been rolled out in our MICU through a diagnostic stewardship team that is led by our antimicrobial stewardship director at UPMC, Huang Nguyen. And here are the preliminary results for the first 74 patients who were run through the pilot program in our medical intensive care unit. And on the left there, what you can see in the 2x2 table is that 8% of patients who fulfilled entry criteria for septic shock in the MICU, in fact, had a positive blood culture for Candida, exactly within that 3 to 10% range that we anticipated going into the pilot study. Going across that table, you'll see that T2 positive results were obtained in 12 of those patients. And if you look at the Venn diagram immediately below the table, you see that we had 6 patients in whom T2 was positive, but blood culture were negative. We had 3 patients in whom the blood culture was positive, but T2 was negative. And then we had another 3 patients in whom both tests were positive. So if you add it up together, we had discordant T2 positive blood culture results in 12% of patients. Either T2 was positive with a negative blood culture, or T2 was negative and the blood culture was positive. And then if you look at patients who either had a positive blood culture or a positive T2, that was 16% of patients. So remember we said that 8% of patients had positive blood cultures. We anticipate that blood cultures are only going to be about 50% sensitive. So therefore, 16% is spot on what we would have anticipated if T2 is working the way we would hope. So encouraging results. So the overall sensitivity shown to the right there was 50%, 3 out of 6, a bit lower than the clinical trial. It's a small number of patients. Another thing that we noticed is that in the real world, blood cultures will often not be drawn at the same time of the T2 test, which confounds the interpretation of the results to some extent. In 3 patients, the T2 result was available before the blood culture, and patients were started on appropriate antifungal therapies earlier than they would have been by relying on blood culture. The specificity in our early experience was 91%, but that assumes that those T2 positive blood culture negative results are false positive for invasive candidiasis. If you drill down, though, and you look at the patient level data, in 2 of those patients, they in fact had an intra-abdominal infection. It was not drained. but it was entirely plausible that these patients had intra-abdominal candidiasis. And then in 2 other patients, there was not a definitive etiology of sepsis that was identified. However, patients did respond to antifungal therapy. So if you consider these 4 patients as possibly having had undiagnosed candidiasis, the adjusted specificity of the test would have been 97%. And here's our antifungal usage in the unit before and after we instituted T2 testing. And what you can see is that we had significant reductions in overall antifungal usage for both fluconazole and caspofungin, and attendant reductions of almost 50% in antifungal expenditures. The duration of therapy pre and post intervention was cut almost in half. So with that now, we've developed other unit-based strategies in different units with different patient populations, and we're rolling these out one by one at UPMC, taking advantage of both positive and negative predictive values in the appropriate settings to either initiate or de-escalate antifungal therapy. For example, here's an algorithm for our surgical intensive care units. Here we're going to have an awful lot of patients who are at risk for abdominal candidiasis, so the model and paradigm is a bit different than for candidemia, but just to show that you can tailor use of the test and interpretation of results and the attendant management strategies based on the specific types of patients and the specific risk they have for candidiasis. So one size does not fit all, but a unit-based strategy is what we've employed. The benefit that we've seen in our pilot studies has been reported elsewhere. So here's another example published recently in the Journal of Antimicrobial Chemotherapy. This was a hospital, a healthcare system, a series of hospitals in the southern United States that instituted T2Candida testing. They did a retrospective study of their patients with candidemia, and after instituting T2Candida, they had significant reductions in mean time to appropriate antifungal therapy among patients with positive results, 6 versus 34 hours prior to the introduction of T2. And moreover, the mean duration of empirical antifungal therapy among people who were subsequently identified as not having invasive candidiasis was significantly shortened with T2, from 2 days in patients who had T2 negative, blood culture negative results, versus 6 days prior to the institution of T2 testing. And overall, the estimated antifungal savings in this study were approximately $50,000, which worked out to an average of $280 per patient tested. So with that, I think it's fair to say that T2Candida is an advance in the diagnosis of candidemia. It can accurately diagnose candidemia at the time of positive blood cultures, and it may identify at least some of the cases that we know we're missing using blood cultures alone. And this includes, most importantly, patients who are already receiving preemptive or empiric antifungal therapy. It has advantages of rapid turnaround time. However, we know that they will be used best in conjunction with blood cultures rather than as a replacement for blood cultures. And it's imperative that you understand your local epidemiology. If you're at a center that sees a large number of Candida species other than the big 5, then test performance may differ than at centers that are seeing almost exclusively the big 5 Candida species. We know that increasing evidence indicates now that combined T2 Candida and blood culture results can predict poor outcomes of candidemia. And something for future studies to look at is that these data suggest it may be possible to identify low-risk patients in whom short-course antifungal therapy is possible. So if patients had T2 negative, blood culture negative results after starting antifungal therapy, this might be a cohort in whom we don't need to give a full 2-week or longer course of treatment. Antifungal treatment and de-escalation strategies that incorporate T2 results can shorten time to initiation of antifungal therapy and can reduce overall antifungal usage. I think major questions right now that'll be answered as more clinical experience accrues is, can we use these management strategies not only to reduce antifungal usage or shorten the time to antifungal therapy, but can we actually impact patient outcomes and improve outcomes? There are questions that will be answered about what the performance in deep tissue candidiasis and other non-bloodstream forms of disease, such as intra-abdominal candidiasis, and there'll be ongoing economic analyses to understand the cost effectiveness, as was suggested in the recent JAC study. So with that, let me move on to T2 bacteria, and I'll basically take the same approach in running through the T2 bacteria data. I'll conclude then by talking about some of our thoughts locally about how we might use this test. So FDA clearance last month was based largely on data from the pivotal trial. These have been presented at ECCMID and recently at ASM Microbe. This was a prospective study performed at 11 U.S. centers. The principal investigators were Lefteris Milanakis from Brown University and Hong Lin, my colleague here from the University of Pittsburgh. Again, a study of adults. These are patients in whom a diagnostic blood culture was ordered per standard of care, and a design in which the blood culture was simultaneously collected along with the whole blood sample for T2 testing. So just to run through some definitions, here, a proven bloodstream infection was defined as patients who had a positive blood culture. But recognizing that blood culture is going to miss a significant number of truly infected patients, definitions of probable and possible disease were also assigned. So probable disease was a patient in whom the T2 bacterial result was positive, but the blood culture was negative. However, a positive culture, either from the blood at a different time of collection or from an extra blood site within 15 days of study enrollment, along with clinical signs and symptoms of infection, was taken to indicate probable bloodstream infection. Possible bloodstream infection was defined as a T2 positive blood culture negative result, again associated with a syndrome that clinically seemed consistent with infection. But in this case, cultures were either not performed or were negative for one of the 5 bacterial species identified by the T2 assay. So almost 1,500 paired samples from unique patients were collected. Overall, 6% or 82 of the blood cultures were positive for one of the 5 species detected by the assay. Were positive. Of these, about half were positive for one of the 5 species detected by the assay, so 39 patients. If we look at the organisms that were recovered from blood culture, showing the 50% that were detected that were the target organisms, Staph aureus and E. coli in 20 and 11% respectively, and then Klebsiella pneumoniae, Pseudomonas aeruginosa, and Enterococcus faecium. The mean time to blood culture positivity was 51 plus or minus 43 hours. The mean time to blood culture species identification was 84 hours plus or minus 47 hours, compared to mean time to T2 bacterial result, including species identification, of 5.4 plus or minus 1.6 hours. So significantly shorter time to diagnosis. If we look at the primary endpoint, sensitivity of the T2 bacteria assay, again, I mentioned 39 patients were blood culture positive for the T2 bacteria targets. Of these, the T2 bacteria test, in fact, was positive simultaneously in 35, so giving you an overall sensitivity of 90%. In 4 patients, the blood culture was positive while the T2 bacteria was negative. And if we look at the breakdown then of sensitivity by target organism, we see 100% for Enterococcus faecium, Klebsiella pneumoniae, and Pseudomonas, 90% and 81% respectively for E. coli and Staph aureus, and the attendant confidence intervals are indicated there. There were archive tubes that were available for patients in whom E. coli or Staph aureus was not originally detected, and among 4 samples that were available for repeat testing on the archive sample, in fact, the E. coli that was originally negative in the archive sample was detected by T2 bacteria, and one of the 3, Staph aureus, was detected upon testing the archive sample as well. So if we look at antibiotic usage on the day that patients were tested, for those who had a paired T2 positive blood culture negative result, the results are broken down by species here, but to summarize them, that on the day of sample collection, only 1/3 of patients in whom T2 and blood culture were both positive were receiving an active agent against the bacteria that the test was positive for. So stated another way, 2/3 of the patients might theoretically have benefited by having the T2 positive result available prior to cultures and initiated appropriate antibiotic therapy earlier as a result of having had that result. So here's a look at the entire cohort. Toward the left, the sensitivity that I mentioned of 90% with the 35 out of 39 patients detected by T2 bacteria. On the right, you can see the large group of patients in whom blood cultures were negative. And here, calculating the specificity, if we use blood culture as the gold standard for specificity, the T2 bacteria specificity was calculated at 89%, or 1,233 patients out of 1,388. So that's with proven bloodstream infection using blood culture as the gold standard. However, if we looked at patients who had probable or possible bloodstream infections in this graph, what we can see is that false positivity is decreased in these groups. So on the far left there in the green bar, 11% false positivity rate if you use gold standard, blood culture as gold standard, 89% specificity. Specificity increasing to 94%, however, if you use probable bloodstream infection as the comparator in the salmon-colored bar. And on the far left for all patients in the blue bar, specificity of 96% if you consider either probable or possible bloodstream infections as the comparator. And then the breakdown by individual species showing similar results at the T2 bacteria species level. So if we use our definitions then, among patients who had discordant T2 bacteria positive, blood culture negative results, we see about 40% of these patients, in fact, fulfill definition for probable bloodstream infection. Another 23% fulfill the definition of possible bloodstream infection. So altogether, about 36% of patients had T2 positive results for which we had no indication of ongoing infection, and presumably this is your false positive cohort. And interestingly enough, over half of the patients with discordant T2 bacteria positive blood culture negative results were receiving antibiotics at the time of testing that were active against the bacteria that was identified. So similar to the theme with the T2 Candida, where the test performed particularly well among patients who were receiving antimicrobial therapy. So how might we use this test in clinical practice? And we've thought a lot about this at the University of Pittsburgh. And to do it, I think you need to understand what's happening with bloodstream infections at your institution. So we reviewed bloodstream infection microbiology at UPMC in calendar year 2017, and it's reflected in these pie charts. So we can see on the left the breakdown by gram-positive organisms accounting for the majority of our bloodstream infections, over 2,300, 950 gram-negative, and then smaller number of fungal or anaerobic infections. And on the right, on the top, you have the gram-positive organisms. On the bottom, you have the gram-negative organisms. So simply to point out that the predominant gram-positive organism is Staph aureus, followed by coag-negative staph, and then the Enterococcus species. On the bottom, E. coli, Klebsiella, Pseudomonas, the big three detected by the T2 bacterial panel, account for the majority of gram-negative bloodstream infections at our institution. So summarizing the results, at our center, 52% of all bloodstream bacteria are on the T2 bacterial panel. This represents just under half of the gram-positives. However, keep in mind that we had a large body of patients who were infected or who had positive cultures for coag-negative staph. And in fact, a large percentage of these are going to be contaminants. So if you exclude coag-negative staph, we got about 67% of the gram-positive infections between Staph aureus and Enterococcus on the panel. And we identified 63% of the gram-negative bloodstream infections. So when a gram-negative bloodstream infection is happening at the University of Pittsburgh, and in fact, what we find is that almost 50% of gram-negative bloodstream infections are diagnosed upon immediate presentation to the hospital. So this is either in the emergency room or upon first presentation to the medical floor or to the ICU. And moreover, if you look on the graph here, days from admission If you add the patients upon admission, times 0, and the patients who are positive within their first hospital day, in fact, this accounts for the majority of bloodstream infections. Moreover, at our center, 71% of the early presenting gram-negative infections are due to the species that are available on the T2 bacterial panel. So how are we treating bloodstream infection empirically? So if we look at our empiric treatment, what we find is that the biggest single agent used among patients who are ultimately identified to have bloodstream infection is cefepime, followed by piperacillin tazobactam, followed by cefepime, and then the carbapenems are third. So for the most part, people empirically are getting broad spectrum Pseudomonas active gram-negative agents. 60% of patients then are also administered vancomycin empirically. And if we actually then look at how we're doing with our empiric choices, in fact, we're not covering the pathogen that's ultimately identified in about 20 to 25% of patients. So we're using big gun antibiotics, and about a quarter of the time, even with that, we're missing the pathogen that's ultimately identified. So I'll review some data that have been published in Journal of Antimicrobial Therapy, and these are the first clinical data published using T2 bacteria in a real-world setting. These are data out of Rome, and what they focused on are emergency departments and intensive care units. And what they found in their experience in the Italian study is sensitivity and specificity of T2 bacteria of 83% and 98% respectively, using blood culture as your gold standard. However, if they use clinical indication of infection similar to what we did with probable or possible infection in the pivotal study, the sensitivity and specificity improved to 89 and 98%. So virtually identical to what was seen in the pivotal study. And again, T2 positive, blood culture negative results significantly more likely in that large cohort of patients who have already been started on antibacterial agents. So with the Italian data and with how bloodstream infections occur at the University of Pittsburgh, how might T2 bacteria actually help at our center? And the first thing, similar to what we showed with T2Candida, is the tests are going to work best if implemented through diagnostic management stewardship teams and incorporated into formalized patient management strategies. And our initial target is going to be emergency room patients and those newly admitted patients within the first 24 hours who have evidence of sepsis, in whom the T2 bacterial panel coverage looks promising at our center, and who account for the majority of all bloodstream infections that ultimately will be diagnosed at our center. And with that, we've begun to think of what algorithms we might use to incorporate the results. So, and these are works in progress. We're in the process of rolling these out. But for example, if you identified an E. coli based on your T2 test, and you had a low-risk patient who was unlikely to have extensively resistant E. coli, an agent like ceftriaxone, rather than the cefepime or piptazo that we're using in most patients, would be appropriate. On the other hand, particularly among our transplant recipients at UPMC, we have significant rates of ESBLs. And in this setting, if you had that type of patient profile, you could use this early result perhaps to stratify to a carbapenem. And I won't go bug by bug through this, but it shows how you can use your local data and early pathogen identification to guide more rational antimicrobial choices. I'll also point out, if you start getting negative results for Staph aureus or Enterococcus, for example, you might be able to stop vanco early. And like I said, we know that 60% of our patients are empirically getting vanco. So you can use positive and negative results based on your local epidemiology to come up with more rational, empiric, and then ultimately definitive antimicrobial management strategies. I think the evidence from both T2Candida and T2 bacteria, however, as shown on the right here, would indicate that if you've got a T2 positive result and a blood culture negative result, and there's some clinical indication of infection, then the best course of action, we believe, is to go ahead and treat based on the T2Candida or the T2 bacteria result, in the likelihood that you'll identify at least some patients who have false negative blood cultures. So in conclusion, T2 bacteria demonstrates excellent performance in detecting bloodstream infections due to the 5 species on the T2 bacterial panel. Overall sensitivity is 90% for the 5 bacteria that account for greater than or equal to 50% of bloodstream infections. As with T2Candida, it's going to work best in conjunction with blood culture results. Specificity is approximately 90% if you use blood culture as a comparator, but in fact maybe in the upper 90s if you consider patients who have clinical signs of infection despite negative blood cultures. The potential advantages for T2 bacteria, as for T2Candida, are rapid turnaround time and the fact that you will diagnose at least some infections that are missed now by blood culture. And in particular, you're going to have superior performance among patients who are already receiving antimicrobial agents. So I think the clinical trial data for both Candida and bacteria highlight the challenges in using blood culture as a gold standard. In fact, with T2 bacteria, we found there was clinical evidence of infection in 64% of patients who had T2 bacteria positive blood culture negative results, and that in 55% of patients, antecedent antibiotics are active against the bacteria that was identified were being administered. So I want to answer questions for T2 bacteria. Do T2 bacteria positive results have prognostic significance? If so, how can we use these in better treating our patients? And what are the kinetics of T2 bacteria in treated patients? What are the significance of serial test results? And can we identify low-risk patients, perhaps those who turn T2 negative rapidly, in whom we could get away with short course treatment rather than full treatment courses? And I think the most important slide is if you're going to optimize the utility of T2 Candida or T2 bacteria at your center, you've got to understand the microbiology and epidemiology of invasive candidiasis, of bacterial bloodstream infections at your center, and you've got to use the test judiciously in specific patient populations with predetermined objectives in mind. And with that, I'll conclude. I just want to acknowledge our team at the University of Pittsburgh. Hong Nguyen is the director of our stewardship and diagnostic management teams. Here's the diagnostic stewardship team, to give a particular shout out to Ryan Shields, Rachel Marini, and Bonnie Falcione, PharmDs, who implemented testing on the ground in our various intensive care units. And with that, I'll be happy to answer any questions. Thank you.
Thank you, Dr. Clancy, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Answer a Question box located on the far left of your screen, and we'll answer as many questions as we have time for. Let's get started. Our first question is, what patient selection criteria should hospitals use for these tests?
So again, Xavier, I think the approach you have to take with both T2 Candida and T2 bacteria is using the test in some patient population in whom there's a reasonable probability that infection by the pathogens that the test is going to detect is present. So for Candida, I don't think this test has utility in every patient in whom a blood culture is collected, because neither positive nor negative predictive value in that setting is really going to help you. But I think once you start getting into your patients in the intensive care unit with risk factors for candidemia, which after about 72 hours in the intensive care unit, most patients are going to have candidemia risk factors, or patients in septic shock, I think are prime targets for utility, and patients in whom both positive and negative test results can help you. I think another large patient population that I really didn't get into in this presentation, although I did allude to it when I made reference to our surgical intensive care unit paradigm that we've put together, are patients with abdominal disease in whom there's suspicion of intra-abdominal candidiasis, either peritonitis or abscesses that may be complicated by bloodstream infection as well. So on the Candida end, I think those are prime populations. But again, you've got to know what kind of patients you're seeing at your center and figure out how the test might best work for your particular patient populations. On the bacterial side, I think the Italian experience and our experience suggests that patients, particularly those with signs of sepsis, immediately upon presentation to the emergency room, or those who've been admitted, say, within the first several hours of hospitalization, at least at our center, those are going to account for the majority of bloodstream infections that you actually diagnose. Those are patients in whom you're making empiric antibiotic choices. In most patients, you're using broad spectrum, oftentimes multiple agents, and they are likely to be infected with the gram-negatives that are on the panel, as well as Staph aureus. Those are populations that I think the test would have real utility. That's where we're first going to roll out the bacterial panel at UPMC. The other population I didn't get into that I think the test would also have very, very good utility is in something like febrile neutropenia, where again, the big 3 gram-negatives are going to account for 75% or more of gram-negative infections that are diagnosed. We know that the vast majority of patients with febrile neutropenia, you never detect a bacterial pathogen, suggesting that a number of these are being missed by blood cultures, and a setting in which empiric broad-spectrum antimicrobial choices are being made. So the ability to identify or rule out staph, the ability to identify things like E. coli, Klebsiella, Pseudomonas that may have difficult resistance panels. These can be quite useful at particular centers in identifying patients and guiding therapy in the febrile neutropenia setting. So at least at UPMC, those are the 2 scenarios we're initially focusing on. But again, it's knowing what you have at your center, where are these bacteria showing up, what are the resistance patterns, and where can we direct the test to get maximal utility, both with positive and negative test results.
All right. Bacteria culture grows faster than fungal. Is there a clinical impact to using the T2 bacteria panel compared to blood culture, and what is the benefit of ID only?
Oh, well, no, I think clearly, I mean, I suppose what the question is getting at is the fact that, the window between, say, a culture turning positive and a T2 positive result is going to be a bit smaller with bacteria than it will be with Candida growing a bit more slowly than bacteria. But we know in the sepsis setting, in the bloodstream infection setting, with bacterial infections, literally every hour makes a difference in outcome. So even shortening from 24 to 36 hours down to 4 hours, at least potentially would have a major impact on outcome with bacterial infections. I think in Candida infections, the impact in time is going to be even greater. Not uncommonly for something like Candida parapsilosis, for example, you might be 5 days or more before a blood culture turns positive. So getting the result within 5 hours versus waiting 2 to 3 days, or in some cases 5 or more days for Candida identification, I think has potentially very important impact. And again, for both these things, hours can make a difference. So for both Candida and bacteria, any window that you close potentially has real impact.
Excellent. There is a higher positivity rate with T2 tests. Is the system too sensitive, or is it truly better detection?
Well, I think, with the Candida data that we have so far, and I think the T2 bacteria data will show similar things once more if it accumulates, is that T2 positive blood culture negative results in at least some instances have real biological and prognostic significance, and I think are identifying the large body of patients who we know were missing by blood cultures. If you're using the test judiciously in patients who have a reasonable pretest likelihood of one of these infections, then the positive predictive values are such that it's worth treating these patients. And I think that's true for both T2 Candida and will be proven to be true for T2 bacteria. Moreover, the benefit appears to be particularly in those patients who are receiving antimicrobial therapy. So what it means in the real world is I can start my antifungal, I can start my antibacterial agent, and even if the blood draw doesn't get done prior to starting the antimicrobial, I can still get value from the test result. And those are precisely the people in whom you will not recover viable bacteria from a blood culture because the antimicrobial is inhibiting the growth of the bacteria. So, I think T2 Candida, T2 bacteria in that setting, and given the importance of time to initiation of active antimicrobial therapy, I think that'll be a particularly valuable use of these tests as we accumulate more experience with management strategies based on the tests.
Okay, we have time for one last question. Can you describe your experience implementing and rolling out the test across a hospital or health system?
Right. I alluded to this a bit, Xavier. I think what places are going to have to do is, what I don't think is going to work is rolling it out willy-nilly across a hospital or across a healthcare system. I think time spent up front trying to consider the patient populations who are developing these type of infections and what the antimicrobial usage and resistance in those particular populations is, I think up front that'll be time well spent, because you'll get your biggest bang for the test by using the test judiciously in those patient populations. So again, based on what we see with candidiasis at the University of Pittsburgh, we felt the best place to roll it out initially was with septic shock in our intensive care units. And then from there, we've moved on to the surgical intensive care units, the high-risk abdominal patients. I didn't show it in the slide, but the other populations now we're going to move out to are complicated cardiothoracic ECMO, left ventricular assist device patients, and our liver transplant cohort. On the bacterial end, as I said, based on what we see in our epidemiology and our resistance patterns, we think the emergency room and early admitted patients to the floor or to the units with evidence of sepsis are where we'll get the best utility with T2 bacteria. So I think these patient population, hospital, and unit-specific approaches are where the test has real utility, and targeted introduction of the test rather than, system-wide rollout is probably going to be most effective.
All right, I'd like to thank you again, Dr. Clancy. Do you have any final comments for our audience?
No, I would just encourage people who are contemplating use of the test to contact centers that have made use of it. And I would also say to places that are using it, it's absolutely imperative that centers report their own experience, because in the end, as a community, this is how we're going to learn. There have been 3 large multi-center studies, 2 with Candida, 2 with bacteria. I think now we know what the test performance is in terms of sensitivity, specificity in the clinical trial setting. What we need are real-world clinical data, and most importantly, we need management strategies that show utility of the test in terms of guiding antimicrobial therapy, and ultimately, most important, in terms of improving patient outcomes. So report your experience as you use the test. Excellent.
Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today, and those submitted during the on-demand period, will be addressed by the speaker via the contact information provided at the time of registration. We would like to thank LabRoots and our sponsor, T2 Biosystems Incorporated, for underwriting today's educational webcast. This webcast can be viewed on demand through December 2018. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.